I'm happy to meet with you. I'm Ann Osborn, one of the senior neuroradiologists here, and happy to give the first of a couple of neuroradiology lectures for you guys. And we're going to do it an introduction to common causes of intracranial pathology. And the way I like to teach is to teach by using radiologic pathologic correlations. So whatever I'm going to show you, where it's possible, I'm going to show you what it looks like at a surgical or an autopsy case, so that then you can see from one to the other what it looks like in pathology and what it looks like on imaging. And so we've got two back-to-back lectures, and we're going to go through number one, then we'll have a quiz at the end, and then we'll go to number two. And I'm recording while we do it. So the first we're going to start with is talking about head injury, and I'm going to focus on urgent and emergent brain imaging. We're going to start with head injury, stroke, and brain bleeds, non-traumatic brain bleeds. That's part one. And then part two, we're going to talk about brain infections, particularly the ones that you might see on an emergent basis. We're going to talk about hydrocephalus or water brain, and then brain tumors. So let's just talk briefly about head injury. If you want to ask what is the #1 cause of death and disability in people your own age, it's trauma. And of all the trauma cases, neurotrauma is the one that results in the most deaths and the most long-term disabilities. We've got 500,000 new cases annually in the US. And of these, about 10% are fatal, about 20 to 40% are moderately severe, and about 5 to 10% of the survivors have permanent neurologic deficits. So it's important to be able to recognize and treat immediately what needs to be treated when patients have head injuries. If we look at neurotrauma, we can divide it into two different categories. Primary injuries, and those are going to be the ones we're talking about today because those are of most acute interest to you, and secondary injuries. The primary injuries are the injuries that occur with the trauma, pretty much at the time of the trauma or within a few hours or a couple of days thereafter. The secondary injuries are ones that usually occur later. And I'd like you to keep in mind as we do this that trauma is not a single event. Trauma is actually a cascade of events, of things that happen in the brain. And besides the initial impact, you can get other secondary injuries that we're not going to be talking about much today, things like brain swelling and perfusion abnormalities and spinal fluid leaks and so on. So we're going to talk about how do we image brain trauma. And non-contrast CT scans, that's non-enhanced CT or NECT, is basically the workhorse of acute trauma imaging. Pretty much been that way since CT started before you were born. Begin by forgetting something. Don't get skull radiographs. They're basically useless. Nobody does it anymore. And if they do, they're not doing the best for their patients. So why use CT? It's widely, almost universally accessible. It's fast, it's cheap, and it's really effective. One thing you should consider, if you have a patient in the ER whose injury is enough that you're thinking about getting a brain scan, think about getting a cervical spine scan at the same time. It's really easy to do with modern imaging technology. We can get both of them in just a couple of minutes. It's easy to do. It's much better than digital radiographs. And it's positive in about 10 to 15% of the patients who have at least moderate head injuries. Okay, let's talk briefly about how we classify neurotrauma. And we're going to be talking about these primary head injuries, the ones that pretty much occur at the time of injury. We're going to talk this morning about skull fractures, extra-axial hemorrhages, and I'll tell you in a moment what that really means, and brain bleeds. We're not going to talk much about secondary head injuries and things like herniations and perfusion alterations today. But let's begin with the skull. It's actually not so much the skull fracture that's really important, with a couple of exceptions. It's what's happening to the brain under the skull. but you need to be able to recognize skull fractures because they tell you at least some type of significant trauma has taken place. And they can be linear, and over here in your upper right-hand corner, I've shown you a picture, an autopsy case of a linear skull fracture. Obviously, this was severe enough that the patient didn't survive it. There's a linear skull fracture here. You're looking at it from the outside on the upper left and the inside of the skull on the upper right, and it continues into the sagittal suture. So this was both a linear and a diastatic fracture. You can see depressed skull fractures, and I'll show you a pretty dramatic example of that. And sometimes you've got a combination of one or more. So if you look at the bone CT scan, that's what this white circle is below. That's the top of the skull in another patient, not the patient who died. That's an autopsy case, obviously above. But we see here skull fractures in the front and the back that extend into the sagittal suture, and you can see the sagittal suture is spread apart. It's diastatic. And so this would be a combination of two different types of skull fractures, linear and diastatic. So let's look first at linear skull fractures on our imaging studies. Sharp, lucent line is pretty much the way, and we see this white arrow pointing to that. A sharp, lucent line is typical for a skull fracture on CT. And on this particular case, we have a bone window and algorithm setting on the top, and the same level of the scan showing the soft tissues of the scalp and the brain. And so where I've put the arrow, that's the skull fracture. But what we really want to do is to look at the brain under the fracture. And here we see this biconvex kind of lens-shaped or lentiform high density area here right under the skull fracture, and that's an epidural hematoma. We're going to talk about that in a moment. There's another area of white lines right here around the tentorium and the falx cerebri, the dura, and that's a subdural hematoma. So here's a fracture. We can see the scalp swelling that overlies it, which is a good sign that you look at to see if you think a lucent line that you see on the skull CT scan is a fracture, or is it just like a suture line. Here's a depressed skull fracture. So you've seen a little linear skull fracture. Here's a depressed skull fracture. This patient was hit in the head with a ball peen hammer, and it blew the skull inwards, and you see it's comminuted. And here on the 3D reconstruction, you can see the depressed skull fracture. So in a depressed skull fracture, the fragments are displaced inwards. They can lacerate the underlying meninges, starting with the dura and sometimes the arachnoid. You can get cortical contusions, traumatic subarachnoid hemorrhages, and so on. But in addition to getting our bone CT scans of the skull, we can do these really nice 3D shaded surface displays, and they can be very helpful for the neurosurgeons when they're trying to plan what it is that they want to do with this. So we're going to leave the skull because really that's the protective covering for the brain. And what's most important in head trauma is what's happened to the brain underneath it. So we're going to look first at extra-axial hemorrhages. And by that, we mean that hemorrhages lie between the skull and the brain. And they can be in three different compartments. There are epidural hematomas, there are subdural hematomas, and then there is traumatic subarachnoid hemorrhage. And at the last part of the lecture, we're going to talk about intraaxial hemorrhages, or those that are inside the brain, things like brain contusions or brain bruises, and then we'll look at axonal injuries. So let's begin with the most dramatic, but actually not the most common of the brain extraaxial hematomas. And this is an acute epidural hematoma. And here you see in our anatomic diagram on the upper right-hand corner of your screen, we see a depressed comminuted skull fracture that we have drawn here as lacerating an artery, a big main artery to the skull that lies right under the skull, the middle meningeal artery. The fracture has lacerated it, and we've drawn this swirl of blood, which is extravasation of arterial blood between the skull on the outside and the dura on the inside. This is a potentially fatal injury. Prompt recognition and treatment of it, particularly if it's causing mass effect, is essential. So remember, it's between the calvarium and the dura. It can cross the midline and sites of dural attachments, but rarely crosses sutures. And that's going to distinguish it from the next type of hematoma that we're going to talk about, the acute subdural hematomas. So this is an acute epidural hematoma. About 90 to 95% of these are arterial origin, just like we've drawn this one with the middle meningeal artery. Others can happen if you lacerate a dural venous sinus with a skull fracture. Those are usually near the skull base. What's important about epidural hematomas is they're biconvex or lens shaped. And so you see that here it looks an epidural hematoma as the blood is extravasated between the skull on the outside and the dura on the inside. It will take on a biconvex or lens shaped. So it looks like this. What's that going to look like on CT scan? So let's look at bone CT. And here we have a patient with a depressed comminuted skull fracture. You can see the scalp swelling overlying it on the bone windows. And when we look at it on the soft tissue windows, you can see that there's this high density lens-shaped blood collection that lies right underneath that skull fracture. This is a classic epidural hematoma, and most of these, about 2/3 of them, are hyperdense or high density. About 1/3 of these are mixed hyper and hypodensity, which typically indicates that there is active bleeding. And that's an especially dangerous type because it's continuing to bleed literally right under your eyes as they're getting the CT scan. So here's bone, axial, soft tissue windows showing the epidural hematoma. And then here's a coronal reformat scan that really nicely demonstrates that biconvex or lens shape. Right below it, we have another case with what looks like a much less ominous skull fracture. It's a small linear skull fracture. It's not displaced, but look at what it did. It made a big hematoma in these areas of iso or hypodensity compared to the adjacent brain, mean that there is active bleeding there. And that means that hematoma is expanding literally as we're looking at it, because the blood is seeping into that space between the skull and the dura, and it's under arterial pressure. Now we're going to turn for the next compartment of hematomas. So we've talked about scalp and skull injuries and epidural hematomas, the ones that are between the skull on the outside and the dura on the inside. Now these lesions, subdural hematomas, are under the dura, and they lie then between the dura on the outside and the arachnoid on the inside. Well, the dura is tightly stuck to the skull, and that's why it's hard for an epidural hematoma to get terribly big. But a subdural hematoma, it's easy for the blood to dissect all the way around under the dura and between the dura and the arachnoid, because the arachnoid is not tightly adherent to the skull and the dura. So it spreads over. It's like a peanut butter and jelly sandwich. If the sandwich is the peanut butter and the bread, the jelly is the hematoma, and it spreads smoothly and relatively concentrically over the whole surface of the brain. And you can see that on our anatomic diagram above and the brain autopsy segment below. And look that that one is spreading pretty much all over the surface of the brain. What does that look like? It looks quite different. Remember, our subdural hematoma was high density and lens shaped. Here, the epidural, and here's the subdural. It's more crescentic. Here's a somewhat small one, and you can see it on the right side of the brain, going around the brain, and then on the inner surface of the brain along the interhemispheric fissure, both behind and in front of the brain. And this is a classic acute subdural hematoma. Spreads widely around the brain surfaces. It may cross suture lines, but not the dural lines of attachment, which is why in this case on the upper right, you see it all over the right hemisphere, and the left hemisphere is unaffected. It too can bleed rapidly, and so if we see areas of mixed high density and low density, particularly when it's producing mass effect, and here you see this is spinal fluid in the lateral ventricles, and they're pushed way across the midline. In the case up in the top, it's compressed a little bit, the ventricles, but they're not shifted. And so this one is not nearly as dangerous as the rapidly bleeding acute subdural hematoma on the case below. Excuse me. Beware the mixed density acute subdural hematomas. Just like that epidural, where we saw that it was mixed high density and intermediate and low density, the same thing is true with subdural hematomas. If you see that mixed density, it often indicates there's rapid bleeding with hyperacute unclotted blood, and it's especially common in older patients who've been anticoagulated, often for things like atrial fibrillation. And so here's an older patient, 3 scans here, 2 axial scans and a coronal reformatted scan, where a patient had a ground level fall, which sounds like it shouldn't be too terrible. It's not a big auto accident, but if you have an unbroken ground level fall, basically where you pass out and your head hits the floor, it hits the floor with an impact of about 20 miles an hour. So a ground level fall in an older patient, particularly an anticoagulated one, can be a very dangerous lesion. And here we see a huge subdural hematoma here. Huge subdural hematoma with areas where it looks low density and high density and kind of in between. And look at the displacement of the lateral ventricles across the midline. This is what we call herniations. And this patient did not survive this, in fact, expired shortly after the scan. So this is a huge subdural hematoma with basically a life-threatening subfalcine herniation. And you can see on the coronal scans, here's the hematoma, and here are the ventricles, which ought to be sitting right in the midline. If they shifted any farther, they'd be coming out the other side. Now, subdural hematomas can be subacute and chronic as well. It takes several days, maybe several weeks, for the hematoma to undergo lysis and the blood products begin to resolve and so on. And here on your upper right-hand corner, you can see a subacute subdural hematoma. It's not purplish red. We've drawn it kind of in pinkish to show that it's beginning to lyse its blood products and so on. And this is a subacute subdural hematoma. Hematomas decrease in density about 1.5 Hounsfield units, which is just a way of measuring how dense something is. And over here in the lower right-hand corner, we've drawn what this means. And so here is blood. And early on, maybe 1 to 2, 4 or 5 days, it's hyperdense, so it's going to be initially whiter or denser than the adjacent brain. As time goes on, and you can see here we're going from several days, and at about the period somewhere between 5 to 8 days, that hematoma is going to be about the same grayness, or it will be isodense with the underlying brain, and then the hematoma will continue to lyse and resolve, and it will finally get down to very low density where it almost is the same density as spinal fluid. So at about the same shade of gray as the brain occurs at around 1 week, between 5 and maybe 8 days. At 7 to 10 days, it actually becomes darker gray than the adjacent brain, and it's easier to see. So it's easier to see when it's white. It's easier to see when it's dark gray, but in the middle, I'm going to show you where it's the same density or grayness, whiteness of the underlying brain can be hard to see. So here's a subacute subdural hematoma, which is basically what we will call isodense with the brain. Here's one that's unilateral. This is what the normal brain would look like, with dark gray spinal fluid overlying the surfaces of the brain and dipping in and out of the sulci and along the interhemispheric fissure. This patient has an isodense subdural hematoma, and it's almost exactly the same shade of gray as the underlying gyri. And we can see the edge of it because there are little dots of spinal fluid in the compressed sulci underlying the subdural. And we can also see the gray matter, white matter interface is pushed inwards toward the midline. Here it is normal on the left side, like a normal gray ribbon, but here we see it displaced significantly medially, and you can see almost the same density of the brain in the subdural hematoma in the subacute phase. It's easy to see this one, relatively speaking, because we can compare it to the opposite side. But when it's bilateral, like this one, you would look at this one and you could initially think this is actually a normal scan. It's really not. Here's a subdural hematoma on one side. There's a smaller one on the other side where you can see the arrow. And this is a bilateral subacute subdural hematoma. Remember that CT is nothing more than a fancy, very expensive densitometer. It does only one thing. It measures electron density. And that's going to give you the whiteness, the grayness, and the darkness on a CT scan. It only does that one thing, but it does it very well. And so what we're looking at are differences in density here. And when it's isodense in the subacute stage, it can be difficult to see. Now, when we get to the chronic stage, this would be somewhere between maybe a couple of weeks and a couple of months and so on. You can get a subdural hematoma that looks like one of a couple of things. You can have serosanguinous fluid where just from gravity, when the patient lies down, the cellular debris and protein is going to kind of float to the bottom and the supernatant is going to float up to the top. Or you can have these loculated pockets of mixed acute and subacute and chronic, and they get scarring and adhesions and they begin to form pockets. And you could imagine that if you're a neurosurgeon, you could go in and take out this one, which is just in one single compartment. But you put your probe in here and you could be in an isolated pocket and drain that and everything else would be left behind. So these chronic subdural hematomas become encapsulated with granulation tissue, and that granulation tissue has happened in this autopsy case below. The granulation tissue is vascular, and it forms these neomembranes that are highly vascular and subject to recurrent bleeding, coagulation, inhibition, and so on, and it turns out to be a real mess. So looking at our fancy, very expensive densitometer with chronic subdural hematomas, you can see here a chronic subdural hematoma is darker at the top and slightly lighter gray at the bottom, but it's a lighter gray than the dark CSF, which you see here on the other side, which is normal. So this is a chronic subdural hematoma. Here's one where you get one with these loculated pockets, and it can look really, really weird, bizarre, with multiple locules. Sometimes you can see fluid levels, as we see here, and these one up at the top. And that's chronic subdural hematoma. So we've talked about epidural hematomas between the skull on the outside and the dura on the inside, making that lens shaped. We've talked about subdural hematomas, a crescentic shape that covers the surface of the brain. And now we're going to talk about traumatic subarachnoid hemorrhage. Subarachnoid hemorrhage is into the subarachnoid space. So it's between the arachnoid on the outside and the peel covering of the brain on the inside. So it literally is subarachnoid. And if we look at the subarachnoid spaces, we'll see that just like CSF goes into the sulci over the surface of the brain, if you've got traumatic subarachnoid hemorrhage, as happened in this fatal autopsy case on the right, you can see acute blood here following the crevices and the curves and the lines and so on over the surface of the brain. What do we look for? Well, we're going to look for that same high density of acute blood, but now instead of having a biconvex shape like it does with an epidural or a crescentic shape like it does with the subdural, now it's going to look like it's curvilinear and it follows the surfaces of the brain. And so here are two cases below where you see the high density of the subarachnoid blood in the sulci on the surface of the brain. Here's blood along the suprasellar cistern here, which would be the equivalent of the here on our coronal drawing above. And you can see it's along the orbital sulci here. Here's another case up high instead of near the base of the brain. And now we see these lines of white in the sulci and over the surface of the brain. And that is traumatic subarachnoid hemorrhage. It is the most common of all the traumatic brain bleeds. Epidural hematomas are only about 5% of traumatic brain bleeds. Subdural hematomas, much more common, maybe 40 or 50% of traumatic brain bleeds. But traumatic subarachnoid hemorrhage is virtually universal in almost all cases of moderate to severe head injuries, and you will find them if you look for them. Okay, now we're going to talk about brain injuries themselves, and we're going to look at cortical contusions and diffuse axonal injury. So cortical contusions are basically brain bruises. In trauma to the skull and the brain rattles around inside the skull with impact, and it bumps up against hard surfaces. And those hard surfaces can be the inner table of the skull, and they can be the hard knife-like edges of the dura of the falx cerebri and the tentorium, and you will get brain bruises. And they look pretty much in the brain like they would if you fell down and skinned your knee. Here's an anatomic drawing looking at what cortical contusions look like, and they are brain bruises pretty much in the gray matter over the surface of the brain. They're often accompanied by traumatic subarachnoid hemorrhage, as we see here. And here, if you look at the autopsy case on your lower left, this is a coronal section. The orbits are down here where I'm moving my mouse, and then these are the brain bruises in the brain right over the bony roof of the orbit. Here is an autopsy case, a butterflied one where they butterflied open the brain so that you see the cortex of the brain, and the brain bruises are on the cortical surface and the subcortical white matter. It happens when the gyri of the brain are forcibly, usually under a lot of force, impacted on the bone or dura, and high impact motor vehicle accident is typical for causing this type of thing. So you get injury to brain surfaces that typically worsens with time. So just like when you first fall down and bruise your knee and skin your knee, you may not see a whole lot of bruising, but it seems to get worse over the next 12 or 24 hours. Same thing happens with the brain. So let's look at another autopsy case of cortical contusions. And we'll see that in this fatal case, the undersurface of the brain, we're looking at the autopsy brain from below, you can see that both inferior frontal lobes, surfaces, and the left anterior temporal lobe here have brain bruises. Look at the CT scan on the right. This is what really bad brain bruising can look like. And if we look at our little anatomic diagram below, where I've drawn in red the areas where you get most commonly the cortical contusions, if you're looking for them on scan, this is where you look. The anterior inferior frontal lobes, the anterior inferior temporal lobes, and around the sylvian fissures. And so on an axial scan here, we'd see them around the sylvian fissures and around the anterior inferior frontal and temporal lobes. Here's a nice example of what happens, how a bony surface, when the brain is moving and impacted against it, can actually stick a bone right up to the brain and cause bruising. And so here's one where we see scalp injury here over the right side of the brain, and we see a prong of bone. This is the greater sphenoid wing with a little high density. That's a cortical contusion. It's a brain bruise. That's in the axial. Here you see it on the sagittal reformatted scan. See that little piece of bone sticking in there? There's the brain bruise. And here we see on the coronal, we can see the anterior frontal lobes, brain bruise right where the bone is. So the brain literally is bumped into the bony skull or the dura, and these are what cortical contusions look like. One concept is that we typically talk about, you'll hear this, people will talk about the coup or the blow site. So in this particular patient that we're looking at, the blow was on the right side and over the top of the brain. And what you look for now is to see not just lesions that are adjacent to this, but 180 degrees opposite. Why is this? It's because when your brain is bumped suddenly, you have a blow where it directly hits, but on the 180 degrees opposite, if it's a hard enough blow, the brain will literally bounce against the opposite side of the skull. And so we always want to look opposite where we see the brain bruise. And here in this case, we see the scalp injury. Always want to check 180 degrees opposite from that. And here is the scalp injury, and it occurred over the top of the scalp as well as on the right side, and 180 degrees opposite, we can see that brain bruise. These often evolve, and they just like your skin knee looks worse 24 hours later with swelling and bruising. Same thing happens with the brain. The initial CT underestimates it, and typically 12 to 24 hours later, what you will see is the brain contusions getting bigger. Here's what a little brain contusion looks like initially. Some just little spots of white. 24 hours later, the patient deteriorates, develops a left hemiparesis, and we can see a huge blooming and bleeding of this contusion. Here's another case below, initial scan. You see kind of the low density mixed with high density. That's typical for a contusion, and it gets bigger 24 hours later. Now, the last type of brain injury we want to talk about is acute diffuse axonal injury. It's a non-impact closed head injury where the brain is literally twisted around inside the skull, and it's caused by acceleration, deceleration, and rotational forces. Something to remember is the deeper the injury, the more serious the consequences. So a deep axonal injury usually has bigger neurologic deficits than superficial brain bruising or the cortical contusions. And so we'll abbreviate DAI. Here's our anatomic diagram, and we can see that the injuries tend to be deeper. They tend to be in the compact white matter fiber tracts like the corpus callosum and the corona radiata. And when we look at them, imaging of diffuse axonal injury, sometimes the CT scan is deceptively normal. This is a 24-year-old male who had a high impact motor vehicle accident, and this is what his CT scan looks like. I mean, you look at that and you say, gee, that looks pretty much like a normal brain, except his Glasgow Coma score was 6, which is like really bad. Well, if you get an MR scan in these patients, we can sometimes see these tiny little petechial black spots there, and those are these axonal, hemorrhagic axonal injuries. Sometimes it can be really bad. Here's an autopsy case. Sometimes it actually can be called diffuse vascular injury because it injures so many blood vessels. Look how little you see on the CT scan. Some traumatic subarachnoid hemorrhage, a little intraventricular hemorrhage, the T2 weighted MR scan. These don't look too bad, but if we do a special scan that we can show brain bruising and blood with, you can just see them all over the place. And that's diffuse axonal injury. So in summary then, our imaging of brain trauma, we spent a fair amount of time on it because it's one of the most important things that we do. The best screening scan is a non-contrast CT scan of the brain with plus minus a cervical spine scan. Look for blood everywhere. It can be anywhere. Remember, acute blood is white or high density on CT. And in general, the deeper the lesion, the more serious the consequences. Surprisingly enough, if you have an epidural hematoma and the brain underneath it is fine, unless it's expanding, sometimes the surgeons just leave those and watch those. But deep injury, like the axonal injury, usually has terrible long-term consequences. Now, we're going to turn our attention to stroke, and then we're going to talk about non-traumatic brain bleeds. So when we talk about stroke, remember that stroke, quote, in quote, is really a clinical, it's not an imaging diagnosis. It basically describes a symptom. It's sudden onset of a neurologic event. It doesn't have to be a thrombus to a big blood vessel like the middle cerebral artery. It can be a spontaneous brain bleed, a non-traumatic brain bleed, and really common ones are hypertensive brain bleeds. So what we want to do is to look for and rule out the presence of a spontaneous brain bleed, and then look for signs of major artery occlusion, the most common one being the middle cerebral artery. And if we just take a look at this little pie chart that I made up that shows stroke etiologies, remember that stroke means sudden onset of a neurologic deficit. 80% of these are cerebral ischemia and infarction. And when a patient comes into the ED and the EMTs have notified the ED that they're bringing in a stroke patient, a whole stroke team is activated because speed is of the essence. And most of these, 80% of these, are cerebral ischemia and infarction. But the next biggest one is primary or spontaneous intracranial hemorrhage. Then we have non-traumatic subarachnoid hemorrhage, venous occlusions, and miscellaneous strokes. So here are the 4 must-know acute stroke questions when a patient comes into the emergency room. First question anybody wants to know is there intracranial hemorrhage, like a hypertensive brain bleed or a stroke mimic? Sometimes patients get subdural hematomas and they don't even know they've had some trauma. Is a large vessel occluded? Is part of the brain irreversibly injured? And is an ischemic penumbra present? So let's go look at these. The first one we're going to look at are these spontaneous brain bleeds, because that's the first thing that all of the stroke teams want to rule out. So primary or spontaneous intracranial hemorrhage, it's a devastating subtype. These patients typically don't do very well, and it's about 14 to 15% of so-called, quote, stroke cases. And most of these are going to be hypertensive hemorrhage in the older patients. So patient age is important. If a young patient comes in that looks like has something like a hypertensive hemorrhage and they're normotensive, chances are it's drug abuse. So the imaging findings in intracranial hemorrhage, ICH. Remember, your CT scan is nothing but a fancy densitometer, and the only determinant of your white and gray and black and intermediate shades is your electron density. Multiple factors determine the signal intensity on MR, and we're not going to go into those today because we don't have time. But when you come in with unexplained intracranial hemorrhage in the ER physician, what do? Well, the first thing you do is a non-contrast CT scan. You may get a CT angiogram, which is easy to do, but not always necessary. And your radiologists are going to be doing these particular things. One of the things that they need to know, that you need to tell us, is the patient hypertensive? Are they on medications? Do they have predisposing conditions, and so on? But I can't tell you the number of times when we see a case from the ER and we got a brain bleed and we go into the record, the EMR, and we try to find something. Sometimes it's hard even to find the blood pressure. We need to know, is this a hypertensive patient? If it's older patient and we see hemorrhage in the basal ganglia and the putamen and basal ganglia, that's pretty much a hypertensive intracranial hemorrhage till proved otherwise. 2/3 of these are right where you see it in this autopsy case, and they often dissect into the ventricles, which is a very poor prognostic sign. Thalamus is number 2, pons and cerebellum, and so on. So we're going to see a hyperdense clot on CT scans that's centered in the putamen and the external capsule. So here are two examples of spontaneous acute intracranial hemorrhage. Both of these in older patients. Here's one where the epicenter is in the putamen, the lateral basal ganglia, and the external capsule. Here's another one where it's in the number 2 site, which is in the thalamus. And these acute hypertensive brain bleeds are typically going to be hypertensive or high density between 1 and 2 to 3 days. Now, not all acute clots are hyperdense. If the patient has a coagulopathy and is anticoagulated, which is our most common thing, you can see really bizarre things like fluid levels, like we've got here. You can see rapid bleeding with a swirl sign. And here, this is actually a swirl of blood that's accumulating here in this particular patient. So sometimes your acute hematomas are not necessarily hyperdense. So we've talked about, is there intracranial hemorrhage or a stroke mimic? Is a large vessel occluded? Is question number 2. Is part of the brain irreversibly injured? Is question number 3. And is an ischemic penumbra present? That is question number 4. So our brain attack imaging protocols start with a non-contrast CT scan to look for intracranial hemorrhage, which answers question 1. And you've already seen examples of that. Question number 2, is a major vessel occluded? A CT angiogram shows you that. And finally, how are we going to triage patients for potential reperfusion treatment? We'll do CT or MR perfusion, and that answers questions number 3 and 4. Your relevant anatomy here is the middle cerebral artery, which is where 80% of major territorial artery infarcts are. So here's the circle of Willis, and here is the middle cerebral artery on our anatomic diagram. Here's an MR angiogram seen from below. So these vessels out to the side are both middle cerebral arteries shown here. And here's your middle cerebral artery territory. When we get middle cerebral artery thrombus and ischemia, you'll see an acute stroke in that particular territory, and we will often see it as a hyperdense clot. As you can see in this autopsy case, there's clot in the middle cerebral artery. It starts right here and goes out all the way laterally. Here is a non-contrast CT scan of an acute middle cerebral artery with thrombus in it, the so-called dense MCA sign. Here is another patient, acute left middle cerebral artery infarct. We can see the high density in the clot, and you can see the beginning low density or edema in the brains in the very vascular territory for the middle cerebral artery. Here's a CTA. Blood vessel is opacified to here, and then the rest of it doesn't opacify. And here's the angiogram, an AP or front to back view of an internal carotid angiogram. You can see the anterior cerebral artery filled out. The middle cerebral artery is thrombosed. They went in with a special clot retrieval device, pulled that thrombus out, and restored normal circulation after mechanical thrombectomy. So that can be very efficient. This is just a reminder of the middle cerebral artery territories, and what your radiologists are doing is looking to see how big the area of hypodensity. And I know that your textbook says, you don't see much in the first 24 hours, and that's really not true. If you look very carefully, you can begin to see all of these areas of hypodensity, and then we give them a stroke score depending on how big that middle cerebral artery occlusion is. And then finally, we'll do a perfusion CT scan. Here's your dense middle cerebral artery scan, a sign on a patient with a CT scan. Here's the CT angiogram, normal right middle cerebral, shut off left middle cerebral, and then you can see the big infarct over here. So we're going to close by talking a little bit about non-traumatic brain bleeds. We've already talked about your hypertensive brain bleeds, and I'm going to close with just what happens when you get brain bleeds in patients of different ages. So determining the etiology of your spontaneous, in other words, non-traumatic intracranial hemorrhage is really important. And we're going to talk about the effect of age on the differential diagnosis. If you've got a spontaneous brain bleed in a child or a young adult, you think 4 things: vascular malformation, drug abuse, venous occlusion or infarct, which is a relatively rare form of stroke except in Utah. Why? Because we live at high altitude and it's dry in the summer and we get dehydrated. So venous thrombi are much more common here than they are at sea level, and vasculitis. Middle-aged and elderly patients, hypertension is number 1. Amyloid angiopathy, which is an age-related thing, is probably number 2. And neoplasm, either a primary brain tumor or metastasis. And we're going to talk about those in lecture number 2. So if you see a child or young adult with a spontaneous brain bleed, they do get vascular malformations, rupture, and give you brain bleeds. And here's an autopsy case, a young patient who died of this spontaneous brain bleed. Here's one who survived, and there you see the high density of the clot. This patient's 5 years old, not likely to be hypertensive, and besides, it's not in a good location. It's not down on the basal ganglia, it's up in the hemisphere. So if you see spontaneous intracranial hemorrhage in a child or young adult, you want to think vascular malformation. Middle-aged adults, different. Middle-aged and older adults, hypertension, amyloid, and tumors. And sometimes you can get coagulopathies. Amyloid angiopathy is the second most common cause of a spontaneous brain bleed in an older patient after hypertension. And here we see a hemorrhage in this patient who came in, found down, no trauma, big brain bleed. Not in a typical area for hypertension, but sometimes you get lobar hemorrhages with hypertension. But this patient turns out to have been demented and normotensive. This is a classic for amyloid angiopathy. There's the brain bleed, and here's an MR scan that shows not only the black of the brain bleed, but all these little dark black spots. Those are microbleeds, and that's typical for what you see with amyloid angiopathy. And finally, brain tumors, 74 years old patient in the ER with confusion and visual problems. They got a CT scan. That's what most everybody gets when they come in. If you breathe on something and hiccup and go to the ER and they say, what's your problem? And you say almost anything that has to do with your head, they'll get a non-contrast CT scan. So this is the best one for you guys to know about. So this is 74 years old in the ER with confusion and visual problems. They didn't know about the visual problems later. It was just confusion. And so the request was altered mental status, which could be anything. We get about a half a dozen of these on a normal basis in a night. And this particular one shows brain bleed, high density white blood clot. It also dissected into the ventricles, and we see a couple of other little subarachnoid hemorrhage there. Turns out this patient had an undiagnosed renal cell carcinoma, and this was hemorrhage, spontaneous hemorrhage into metastases. So in older patients, you think hypertension, amyloid, and neoplasm, either primary or metastatic. And in younger patients, you think of vascular malformations, and in young adults, you'd also want to think about, unfortunately, drug abuse. So the last thing we're going to talk about in the last couple of minutes here, and then we'll go to our quiz, is subarachnoid hemorrhage and aneurysm. So among the brain bleeds, hypertensive hemorrhage is probably the most common one that we see in middle-aged and older adults. Subarachnoid hemorrhage and aneurysms occurs at all ages. It's rare in kids, but everybody else gets it. And one of the most common symptoms is people come in and say, I have the worst headache of my life. And some of them will describe it as a thunderclap headache, which means like a bolt of lightning here. And they will say it hit so hard it like made me drop to my knees. Keep in mind that there are many causes of thunderclap headache, and subarachnoid hemorrhage, aneurysmal subarachnoid hemorrhage, accounts for only 4 to 12% of these. Having said that, if you have aneurysmal subarachnoid hemorrhage, thunderclap headache, or worst headache of my life, is the top symptom. But a lot of people come in to the ERs with thunderclap headaches, and most of them are not aneurysm bleeds. But we need to know how to pick these up because a ruptured bleeding aneurysm is a neurosurgical emergency. Your best screening scan, your old friend, that non-contrast CT scan, sensitivity is virtually 100% if it's obtained in the first 6 hours after the onset of headache. And that's key. If you get it in the first 6 hours and your non-contrast CT is negative, you don't need to do a lumbar puncture if the CT is negative and the neurologic examination is normal. If the non-contrast CT shows what looks like aneurysmal subarachnoid hemorrhage, then you're going to get a CT angiogram. And this is what it looks like. So here's aneurysmal subarachnoid hemorrhage. It's basically arterial blood extravasating into the subarachnoid space. Here's what it looks like at autopsy. A ruptured aneurysm here bled into the subarachnoid space. This patient obviously died. About a third of the patients who have a ruptured brain aneurysm will die almost immediately. And this is what aneurysms look like. They're usually a ticking time bomb until suddenly they rupture. And when they bleed into the subarachnoid space, this is what you get. So the non-contrast CT is going to show, it looks like you took white ink or paint and dumped it into the subarachnoid space. So instead of the dark gray for normal spinal fluid, like you see here in the temporal horns of the lateral ventricles, you see white all over. And if you look at the reformatted scan in this particular case, it's showing it in the suprasellar cistern and in front of the pons. It's going to be high density or white. And here is an example, another patient. Here is another patient, subarachnoid hemorrhage with a focal clot in the interhemispheric fissure, which turns out to be where this aneurysm is. And here's the CTA, nicely shows the aneurysm. Here it is on DSA, and here's our three-dimensional reformatted scan of the aneurysmal subarachnoid hemorrhage. And we can look at where the focal hematoma is, like this one, and pretty much predict where the aneurysm is going to be, just a different case. Okay, so emergent and urgent brain imaging, head injury, stroke, and brain bleeds. So now in the next couple of minutes, we're going to take our quiz cases. So here's your question number 1. 74-year-old anticoagulated obtunded female, left hemiparesis after ground level fall. What is the most correct diagnosis given these imaging findings? Non-contrast CT scans, you've got 5 choices. I'll give you a few seconds to read them while I take a sip of Nectar of the Gods Diet Coke. And write down what your answer is. Okay, question number 2. 83-year-old female found down. What is the most likely diagnosis? You've got 5 choices. Question number 3. 27-year-old male with thunderclap headache. What is the least likely cause of his intracranial hemorrhage?
For this question, how would we differentiate between 2 possibly good answers for someone of who's 27?
Who's of 27?
Mm-hmm.
That's a good question, especially because we did not talk about vasculitis, so you know it's not going to be that one. And yeah, could be it. You're right. What is the least likely cause of his intracranial hemorrhage? There is one answer here, which you really see only in old patients. Do you see brain tumors in young patients? Yes, so I'm giving you a hint on that one.
Okay, thank you. That's all I needed. Thanks so much.
You're welcome. And what percentage of thunderclap headache is caused by a ruptured aneurysm? If you have trouble with your short-term memory, you probably not answer this one because we just covered it about 3 minutes ago. And question number 5, which of the following statements regarding thunderclap headache is not true? And I know you're not supposed to write questions like that, but I couldn't think of a better way to put it. So humor me and find the one that is not true.